within the repository. And within the repository, we have a common data model. The common data model that we are currently using, the OneFlorida Plus uses, it's called the Observational Medical Outcomes Partnership, or OMOP, and CDM stands for Common Data Model. And this is basically, I'll put it as a guideline or as a framework to how you should have your data tables and what information should go into each one of them. Excuse me. So this is a representation here of a data table called person, where you find information about the patient, right? You might find an age, or you might find a date of birth, depending on kind of data you're sending. And then you have observation period, which is a different data table that stores, let's say, the admission and discharge dates within a hospital stay for that specific patient. And all of these different data tables here, they're connected to each other in some way, because I want to be able to know if I'm interested here, if a patient use like a pacemaker or some sort of device, I go into this device exposure data table here, but I need to know exactly who is that patient, or what is that patient's age, what is their race, ethnicity, and so on. So I need that table to be connected to the table person. So there's all of these different connections here. And by establishing a set of data tables that I want to use, and the relationships among them, I can then just get the data that I'm extracting and put into these appropriate data tables without me having to necessarily have all of these different formats. So I like to bring here just a few definitions about common data models for those that are not so familiar with this concept. But the purpose of a common data model is really to provide a way to organize data that can enable optimal analysis and the operational needs of a healthcare system. But it is also used for data protection. And it's also used for design of the domains. So the way that you're modeling the data, so it's centered on the person, not the health system, which is really good, because when you have a person or a patient that has been seen by different hospitals, you have the data about those patient stays at the patient level. So if I go in and I extract, I put in a request for data for all adult patients that have a COPD medical diagnosis or something like that. They'll extract all of that patient the data from me at the patient level, no matter which hospital that patient came from. So if it came from hospital A, hospital B, I get all of that data at the patient level, which is great. It also allows us to integrate standardizing vocabularies into the framework. The most commonly used ones are, for example, SNOMED, ICD-10, and LOINC, those mostly used for medical purposes, but it also allows us this scalability. Because we have a common data model, we're able to optimize data for processing and computational analysis, including databases with up to hundreds of millions of persons. So for example, within our data trust here, or data repository, the OneFlorida Plus, we have data for 21 million patients. And imagine that each one of those patients have thousands and thousands of data points. So it's really billions of clinical observations. So here, I'm bringing just a few examples of other common data models in case you have heard from them. PCORI being one of them, also used within the OneFlorida Plus. The Odyssey is the one where OMOP comes from, which I shared with you is the one we're using for this project. But there's also I2B2, which is a common data model as well. So going back to the project, once we've identified what the nursing data tables are that we wanted data from, which are these ones here, we had to map them to the common data model, OMOP in this case. So when you're performing the mapping across tables, you not only look at what the purpose of a table is, but you also need to see what the columns within that table are, what data elements can be stored, what can be the size and type of those data elements, and so on. So by looking at that and doing the examination of the OMOP common data model and our data tables, we were able to leverage 4 of the existing data tables within OMOP. So for example, condition occurrence is a table where all of the medical diagnoses for patients are documented. And as part of our project is where all of the nursing diagnoses for our patients are also going to as part of the pipeline. The fact relationship tables are the tables where we can preserve a linkage between a nursing diagnosis and an intervention, because within our health system, this kind of documentation is allowed, but also the linkage between a nursing outcome and an intervention. So those things are preserved here within the fact relationship table. The procedure occurrence table stores all of the kind of procedures, even surgical procedures done for patients. And that's where we're sending the nursing interventions to as well. Then we have the provider type where it stores if a provider is a nurse or not, going to the provider table within the common data model. But all of these other data tables here, we didn't have anywhere to put them within the existing framework. So we had to create new tables within the data trust that would store the information we were after. So problem contact, we basically replicated the same table and so on. And what we did to make sure that these data tables are linked to these ones here is by using the same primary keys across them. So that way, if I want information about the nursing outcomes, I can get the same way I can get information about the nursing diagnosis from the condition occurrence table. And as part of this process, every time you're sending data somewhere, you need to assess the quality of that data, right? And since nobody had worked with nursing data before as part of a large initiative like this one, we had to develop our own data quality checks to make sure that every time the health system gets the nursing data, standardizes it, and sends to the data trust, we're not missing anything as part of that process. The data that is going is data of good quality. Otherwise, what is the purpose, right, of having data available if it's not good data? So we had developed over 90 data quality checks that ensure the quality of this information we're making available. And as part of this pipeline, what we're doing is that every 3 months, the health systems that work with us, they extract care plan data from the previous period. They standardize it and then they send it to the data trust. So it is a cyclical but also ongoing process, which enables us to get data for all patients being hospitalized at a specific time period. But what happens, which I think you all are anxious to know because this is a part that plays within the nursing terminologies, is that the hospitals do not speak the same language. And I put speak between quotes because all of the hospitals here, they do document in English, but it's still not the same language in a sense that all of the different terms, for example, used to document what we call nursing diagnosis, they're not from a terminology. They're not from a standardized terminology. You can see some of them are kind of bored by like from some terminologies, but a lot of them, the health system themselves develop their own list of terms. So we have a local language being used. We have duplicated terms with unique codes. So for example, activity intolerance, which is a problem documented in one of our health system, it appears more than almost 10 times here, each of these times as a unique code, which means that the computer understands each one of this same nursing diagnosis as a different one, which poses a lot of problems when we are analyzing the data. But also, there's no definition or other relevant information to these terms here. So when a nurse goes in and she goes to document, he or she or they go to document a care plan, they can select on a term, but that term comes with no definitions or anything like that. So that might cause issues where nurses from different units interpret those different patient problems or nursing diagnoses differently, which causes a lot of issues when we think of data quality. So because we are working with care plan data from two different, very different health systems that each one of them uses their own local language. So none of them uses a standardized nursing terminology. We had to map those terms. So initially we were like, let's just do a manual mapping process. We are going to get all of the terms, the nursing diagnosis, outcomes, and intervention terms the nurses are using, and we're going to manually map those to NANDA, NIC, and NOC, or NANDA, NOC, and NIC. And we wanted to make sure that our process was robust enough and could reduce bias as much as we could. So initially, what we did is like, let's start with a subset of problems, which were being mapped to NANDA, and goals which were being mapped to NOC, and let's do that process manually. So we had 5 different mappers independently manually mapping each one of the local terms to one NANDA or one NOC. So we started with 277 local problems and 443 local goals. We created some sort of a rule for us that if at least 3 out of the 5 mappers selected the same NANDA or the same NOC, we would consider that a match. If that was not the case, we would resolve those discrepancies through consensus. And we wanted to make sure that our own mapping was also validated by the actual nurses creating care plans within our health system. So we had 4 different nurses who are members of our team, and those are nurses working every day at the hospital. They would independently review all of the mappings we have done, and they would tell us if they would agree or not that that NANDA or that NOC specifically represented what was the goal or the nursing diagnosis or the problem they were seeing with their patients. So we did this process, and then we were able to map 230 problems to nursing diagnosis labels, 41 of those nursing problems to classes within NANDA, because the nursing problems or the patient problems were sometimes so specific or sometimes containing more than one problem. For example, I find it funny because it's so counterintuitive, but one of the patient problems that nurses document within this specific health system is called pain acute and chronic. So how can a patient have pain that is both acute and chronic within the same problem? So because we had basically 2 different problems represented within the same term, we couldn't map it to both acute pain and chronic pain, because in the database or in the data repository, it doesn't sustain a mapping of one local term to 2 standardized terms. It needs to be a one-to-one mapping. So in some of those instances, we had to map a local term to a class or to a domain within the terminologies, which helps with the standardization, but it decreases some of the specificity, right, of what we're trying to measure. But that was the solution we came up with. So this worked okay for the problems and goals we were mapping in the initial phases of the project. And then this work has been published if you want to check it out. But then we were like, manual mapping process does take a village, right? As you can see on the previous figure, we had what? At least 5, 9, 12 people working with us to perform this mapping. It requires time, it requires effort. It was a process that took us months, and these are for terms from only one hospital. When we went to look at the data that we would have to map for interventions, there were over 1,000 interventions that nurses were using locally to document care plans. It would be somewhat unfeasible for us to manually map all of those. We wouldn't just have enough time, it would take us a lot of time. So we were like, what if large language models can help us or can assist us in this mapping process? Especially because we wanted to make sure that we are creating a process that can be reproducible, right? Specifically because we're mapping terms not only from one health system, but from a second health system very different from that one. And just having a manual process to do that might not have been sustainable to our project. So with the advance of publishing and availability of large language models, we wanted to test it out if those could assist us in the mapping process. So as part of our large language model strategies, we had to start with what the guiding question was, or the guiding direction for the model was. We needed to find a way to address hallucinations. We needed to find a way for the machine or the AI to select the appropriate answers we wanted. And this was a process that took iterative refinement. So the different large language models we tested several ones. We tested open source ones, such as BERT, We tested the different GPT models available through OpenAI. So GPT 3.5, GPT-4, GPT-4o, and we're now in the process of testing a different large language model available within our institution, which is called Gatortron. But it took us several rounds of prompt engineering to get the best results. So first, we started with the very simple phrase. We wanted to create a mapping between medical terms and their NANDA equivalents. But just by using the word NANDA here, it created a lot of hallucinations because then the GPT system thought that they should use its own knowledge about what NANDA is to bring whatever the results they thought the machine thought were the correct one. So we went to find a more specific and more detailed kind of prompt to see if we would get better results. And this prompt strategy that we used is when we were interacting with the system, with GPT through the chat option. So we were using chat GPT to do this. But ChatGPT by itself has a lot of constraints, right? First, it's really hard for you to constrain the knowledge source that it can use. So it's going to use all of its training to bring you the answer you want. Second, when accessing the GPT model through the chat interface, you also have restrictions in terms of the different tokens you can use. So the type of material you can input and you get out is somewhat limited. And it's also not as secure because if you just upload a file to ChatGPT, OpenAI, the company, will use that to further train its systems, right? And that's not what we necessarily wanted to do. So we were like, what if we use an application programming interface or API to help us in that process? And that meant that instead of interacting with chat, well, with the GPT model through the chat interface where you go and you ask a question, we would connect GPT to a specific knowledge base, and then we would program the query that we wanted as part of that. So it would be a secure pipeline to put the information we wanted and hopefully get better answers out of the model. And when you use GPT or other LLM models connected to an external and secure database, but also when you look at the programming or the coding of that model specifically, you can adjust for different hyper parameters like temperature. So you can kind of put a cutoff as the type of answer that GPT will return to you. You can also ask for a specific number of answers and so on. As part of our, excuse me, having some water. As part of our work using GPT connected to an API, we used a framework called blockchain, which is just a different, specific way of making those connections. So the connection between the GPT model and an external database. In the case, we use ChromaDB. And by using this, I'll call it connectors or this pipeline, we were able to use a more integrative approach to a database where we would put the nursing terminology content and the query that we would do for that specific knowledge source. So this is a table, I'm sorry, not a table, a figure demonstrating a little bit what this pipeline looks like. In this process of putting your knowledge source in a specific and separate database from GPT and using it to bring back to GPT a smaller knowledge source or a smaller number of answers is called retrieval augmented generation or RAG. So this is the method we're using here. And basically what we do is in this database here, which we are using ChromaDB, but any other database can be used, we put the nursing terminology content. So we could put here, for example, the nursing diagnosis, their definitions and defining characteristics, or we could put the nursing interventions, their definitions, the different activities, classes, and domain, however much information we want to put here. As part of putting this information here, we put this content or this database and the content in it, the data in it, as part of a pre-processed document or we pre-process process the documents, where we split each one of the data points or the combination of a label and a definition into specific chunks. So in the case here, we use this process to map our local interventions to NICs. We separated NIC labels and their corresponding definitions into different chunks. Those chunks are sent to an embedding model. And an embedding model is a different kind of AI that transforms each one of those words into vectors. Because as you know, computers don't understand words, right? All of the different letters and words that are transformed into numbers, and computers understand numbers. So this is what this process does here. It transforms a combination of a NIC label with this definition into a number or into a vector. And then within the database, that information about the terminology is stored as numbers, as vectors. So this is what is happening on the pipeline here above. In the pipeline below, we are interacting with GPT. So we send our question to GPT. So we said, bring me the 20 most close NICs to the local intervention or something like that, for example. That query is sent to this database here. So the query sent is not GPT accessing the query directly. The query only is sent, and then the database brings back the 20 NICs that are closest in distance to the local interventions I'm giving. So they have kind of the same size, but it's not only about the number of words, but it's about the meaning of the words as well. But then what gets returned to us are the 20 NICs most closely related to that specific local intervention. And then only those 20 NICs are given to GPT, and then GPT selects what GPT thinks is the best NIC for that specific local intervention. So instead of us giving the entirety of the content of the terminologies to GPT to look at and perform the mapping for us, we give a subset, and it can be 20, can be 10, can be just one NIC, depends on what the purpose is, but we give just that subset or just that X number of labels or K number of labels to GPT to process. And that has improved our performance, as I'm going to show to you here on the next slide. But this is just to bring what embeddings are, which is this part of the process here. So embeddings, they help computers associate each word with a list of numbers. So all of the words are kind of transformed into numbers. And those that are more close, they're gathered together here. For example, the word food is very close to the word foods, meat, supply products, or supply. And then you kind of group the words that are somewhat similar to each other. And that's what the embedding does. So similar words are grouped close to each other, and dissimilars are far apart, and you can see by their distance as well. So here is the query or the prompt we were using as part of this pipeline. We have the question here. So we have, when we're using API with GPT, you have to give different roles to the prompt. So you have the human saying, giving the context about the standardized term and its definition. This context here is bring through this. So the embedding brings to us the 20 NIC labels and their definitions, or just the NIC labels. And then we ask the question, basically, which NIC is closely related to the standardized intervention that I'm giving as part of the query, which will be not the standardized, the local term here. And when we do that kind of process, it helps us increase a little bit the accuracy of what we're doing or of the AI model we're using. So here we are comparing the results of the LLM or the large language model performing the mapping versus of the human performing the mapping, because we did map a subset of interventions manually as well, so we could see how accurate the models are being. So when we think of the NANDAs, the large language models accurately mapped a local problem to a NANDA about 70% of the time when we use GPT-4 and 70.1% of the time when we use GPT-4o. When we think of the goals, so GPT selected the right NOCs to the local terms about 56% of the time, And then when we think of the interventions, it was only about 45% of the time. However, when you look at these results and compare them to the manual mappers, they're very similar. So inter-rater reliability we got for manual mappers when performing mapping of local interventions to NICs, it was about 46% only and so on. And the reason is because sometimes the local interventions are so unspecific or they could mean so many different things that it's even hard for a manual mapper to select the same NIC as another manual mapper. So although the results are not as good as we would hope to have just GPT do the mapping by itself, the results are good enough that GPT can actually help us manually do the process. So what we're doing here is that we're combining both the large language model and the manual mapping process when performing the standardization of the data. So we have our embedding model generating the top terms, standardized terms we want, and then we give the manual mappers only those 20 terms or 10 terms. We don't give the manual mappers the entirety of the terminology to select a standardized term from. So that has reduced our time in our mapping time in 3 times, and it has also increased and or improved our inter-rater reliability among the mappers. We're getting mapping results over 70% when we're combining both the manual mapping and the large language model mapping. So GPT models by itself, they are comparable to human mappers, but they lack the accuracy for fully automated mapping, which means that we cannot trust the models by themselves now to perform a task like this, but we can use it to assist manual mappers in performing the task, which is what we're doing at this point. And now finally, since we're done with the care plan data extraction, we have standardized the tables, we have standardized the nursing data elements too. So the data going into the data trust is represented as NANDA, NICS, and NOCs. It's not the local term, it's the standardized terminologies. We are now integrating the data into the data trust. So the nursing care plan data is available at 2 different places, at the OneFlorida Data Trust, but also at the local hospitals, and it's linked to all of the other EHR data. So as part of this project, we are improving this data repository, or the OneFlorida Plus, as we were doing the ongoing integration of nursing care plan data for about 2 million adult patients. So for out of those 21 million, 2 million of them will have some sort of nursing data represented that was documented for them during their hospital stay. And it is our hope as a team that once this project is done, so the project goes into 2026, that we're going to finalize the infrastructure and all of that, then we'll get more funding to expand this infrastructure to all of the other remaining 17 academic institutions or health systems to also send nursing data about their patients to this repository. So I always like to bring reasons why we should look at nursing data again, because now you have all of this data available. Why should you be using it in your own research or clinical question you have or quality improvement project? You're able to analyze patients' problems across different populations and health systems. Imagine being able to answer questions with patients from 12 different hospitals, or even more than that, 12 different health systems. You're able to track what is working, what is not working. You're able to measure the impact of nursing interventions delivered. And that is so big because it really shows the impact of the care that we provide as nurses on different patient outcomes. But it can also be used as a measure for so many different things, such as reimbursement for nursing care, for example. It also enables us to assess patient to nurse ratios and its impact on care and outcomes, because we have all of that metadata, right? Along with the nursing care plan data. So you're not only including in your models what were the nursing diagnoses documented for that patient, but you're also including all of the different nurses that provided the care. What was the shift length for those nurses? What was the continuity of the care? Did you have the same nurse providing care 3 days in a row, or is it different nurses? Was that nurse taking care of your patient alongside with other 5 patients on that shift? So all of that metadata is very rich to allow us to compare and contrast nursing care across different units and health systems, You can examine different outcomes of interest, including unplanned readmissions, which is the case of our project. But I think most importantly, it allows you to measure the contribution of nurses and other healthcare professionals to patient care. Because you already have the data documented by physicians and some other allied health professions. Now you're going to have the data documented by nurses as a representation of the care they're providing. So that makes your prediction models and your research questions and your answers much more robust and richer and can inform patient care better. So I'm kind of finalizing here. I like to leave my presentations with kind of a phrase as to why this is so important, why looking at nursing care is so important. It's just because measuring the contribution of the different healthcare professions to patient care will unlock knowledge that can be used to improve patient outcomes. How many times we look in the literature and we see all of those prediction models, some of them even complicated using different machine learning techniques, but then you don't see any representation of nursing. And you know there's so much more care that happened or will happen for those patients that are not being taken into consideration with those models. So those models will never be 90 something percent accurate or something like that because we're not including the biggest component or profession of healthcare within those models, which are nurses. And patient outcomes, they are interdisciplinary sensitive. So that's why it's so important to measure the contribution of the different disciplines in healthcare to patient care. So I leave you with a thank you. I hope this was informative and not too much. You let me know if you have any questions. But here is the QR code for my LinkedIn page if you'd like to connect with me there. I'm very responsive on LinkedIn, but also my email. Thank you.
Thank you so very much for this very informative presentation. I think what you've done is created a model for other states and other entities to include their nursing data into data repositories too, as well to show the value of nursing data across different entities. I think back to with COVID and when we were trying to look at COVID and also the COVID long COVID research that's being done, and looking at the not only the amount of data but the quality of data going forward to look for those signals that how can we predict if someone is going to have long COVID, and we just don't have that kind of data at our fingertips currently. So I think your
Mhm.
work really does show the path forward on how to do this. At this time, I would like to open up the floor to questions. And you can do that by unmuting yourself in the lower right-hand corner. And feel free to ask questions this time of Dr. Maciera.
Thank you so much, Christina. And I would just like to say hi here to some of my colleagues that I see attending. Sana, Patricia, Professor Gina, thank you so much for coming. Appreciate you being here. Always good to see familiar names.
Well, in the Q&A session, will the session be recorded? We recorded, yes, it partially recorded, but we will take care of the first part of that. And there is another question. Can you speak to how standardized definitions are needed and how the codes were assigned?
Yeah, absolutely. Thank you, Laura, for your question. So, the way that we're using, so to first respond your the first part of your question about how standardized definitions are needed. So, standardized definitions are needed a lot because they bring more context to a specific concept, right? What happens within the health systems that do not have standardized terminologies currently being used as part of their documentation is that they just have a label, for example. And then that label doesn't come with any definition or anything like that. So sometimes that label is so unspecific that different nurses within the same unit understand that label differently. So they might document a problem to their patient thinking it means X, but then the other nurse thinks it means Y. So, excuse me, having a definition really helps when doing that process because then everybody um, can use the term the same way. And then about your question, how the codes were assigned. So the local codes, like for example, on that slide that I showed an example of terms from the health system and their codes, the local codes there are assigned by the institution. So whatever coding system the institution uses, it can be like 1, 2, 3, 4 or 5, 6, 7, 8. It just comes from the institution and there's no true meaning to that code. It just helps differentiate one term from the other. So, but as part of our mapping, we're leveraging the codes as they are within NANDA. So for example, when we're mapping pain acute from the local list of terms to acute pain from NANDA, we map the local code to the code for acute pain within NANDA. So we're not recreating codes that way. And I see your other question here. You're interested in how the term assess is used. I see it often used as an intervention, and that's a great comment, Laura. It that is an issue when we think of terminologies not being used at the front end for documentation, because then there might be even a misunderstanding of what necessarily is a nursing diagnosis and what would be a nursing intervention. So with some of the local uh, language we see, some nurses do document assessment or something like that as part of a patient problem instead of being an intervention. And that causes a lot of issues. Some of those terms are terms that we had to map to an NANDA class, for example, or an NANDA domain, because there's not really a problem you're addressing when an assessment problem, right? It would be an intervention that you would do. So I understand your question. I hope I'm answering them, Laura. If you'd like to unmute yourself and talk a little bit more, but I hope I answered um, your question. And I know, Christina, if you maybe you have some comments on that, or Frizo maybe. Dita.
Yeah, I have nothing to add to that. Although I have a question I would like to ask, and that is when you're looking at the nursing documentation, I know that different hospital systems and different EHR vendors will contract with different third-party terminology vendors to provide those data dictionaries to use in nursing documentation, and for the care plans, for example. So we're using disparate data. Some will have the nursing terminologies in there, and some will provide what they call provider or clinician friendly terms. Were there any mapping rules created and employed during the manual or large language model mapping processes?
So yeah, so Christina, to address the first part of your comment, so one of the health systems we're working with, they do use a third party care plan content. And it comes from a very well-established and known publisher. And it's interesting because the terms coming from this third-party content, they are better than the ones that our other health system develop locally, but they're still not the entirety of what a nursing terminology would be. So a lot of the terms we see are actually medical problems that nurses are using to document nursing diagnosis. So they're still not as good as if you were just to use the standardized terminology by itself in the EHR, right? But when during our manual mapping process, we did develop just a few set of rules, maybe 3 or 4 rules as to how to guide our manual mappers to perform that mapping, right? So one of the rules that we used was that we would tell the manual mappers to try to select, like for example, a NANDA that would represent to the best their understanding what the problem of that local term meant. But also, we said that if there was an instance where, for example, the local problem represented 2 or more issues, patient issues, like for example, the one for where we have a local problem that said patient acute and chronic, which within then there are 2 different nursing diagnoses, right? We would direct the manual mappers to initially map that term to the word other, and then we would further map that to either a class or domain with the help of the nurses, because we didn't want to kind of enforce that it needs to be a one-to-one mapping at all times. But For some of the mapping, unfortunately, sometimes it had to be so intuitive because of the nature of the local terms that we didn't develop very strict rules when performing the mapping. That's why we had to deploy or employ 5 different people performing the mapping of the same terms independently, because that way we could make sure that we were addressing some of the bias at least. So for each one of the local terms we mapped, we had 5 different people mapping that same local term independently, and then we would reach a consensus when needed. So those were kind of most of the rules we used, if that answers your question.
Yes, thank you. There's more questions that have come in the meantime.
Oh,
You
I see
mentioned,
Cheryl here. Sorry, go ahead, Christina.
okay, go ahead. Go ahead. Do you want me to read Cheryl's question for you, or do you want to just
Oh no, I can read it here.
yeah.
Thank you. Hi, Cheryl. I'm glad you're here. So you're saying that that you mentioned that you're mapping to NIC. Do you find that the NIC labels are used infrequently, and the NIC activities seem to be more what nurses are designated as interventions? Yes. Yes, Cheryl. That's something we see a lot, specifically to the health system that developed its own language that is not using the third party component. A lot of what they call interventions are at the activity levels of NIC. So it seems that the nurses, I don't know, because of the way they're taught or the way they practice within specific institutions, it seems like they need to see what the activities are, or they need that information at the activity level, because sometimes a label might be somewhat in a specific, or they cannot see, not in a specific, but a little bit broader, that they can't see exactly how that label translates into the activities or the actual care they're providing. So they want that thing on the activity level. But I think it would be mostly on helping the nurses understand that they do perform the activities as part of the care, but they document the intervention, because several activities, you might have one activity being performed more than one time, the same one, but the focus or the intention of that activity is different depending on the intervention, right? So they need to be documented at the intervention level. I think would be more just to be able to find within the EHR, for example, on the lovely day that it comes in the future, hopefully that we have standardized terminologies in the EHR, it would be important to that the nurses can see both the labels and the activities while they're documenting. So that way it can help them define within their documentation what would be the best label, the NIC label. But yeah, I guess I went in circles just to say yes. Most of the local interventions are the activity level. And that was a little bit of a challenge for us when we're performing the mapping too, because you might have different activities under the same activities under different NIC labels. So how do you do that? So that was a little bit tricky, but we were able to do it. I hope that answered your question, Cheryl. Um, I see here a question. Christina, would you like me to keep going through the questions?
That would be great. Yes.
Okay, great. I see a question from Sylvia here. Uh, Sylvia is asking if I could give one example on how I plan to utilize the research results in practice and further research. Thank you, Sylvia, for that wonderful question. So, the part of the project that I presented here is more on the infrastructure building part of the grant itself. But now that we have all of this data available, we're moving to our second aim, which is to build the prediction models for unplanned readmissions for a population of interest. So what we're doing now is analyzing all of this data, not only the nursing data, but all of the other EHR data for our population of interest. And we're performing different machine learning techniques and statistical methods to find what are the potential predictors for those unplanned readmissions. So, is there anything that the nurses are doing that are maybe preventing the patients from going back to the hospital in a good way? Or is there a lack of care in some area that we need to address better to prevent those patients from going back to the hospital when they shouldn't? So we're now really looking at the data to help answer some of the clinical questions we have. And because we're making data available to so many different populations, we're hoping to continue using this data to answer clinical questions and even make practice changes for other patient populations. I work a lot with the cancer population too, so I'm looking at that data for other projects to inform cancer care and so on. But I do hope that other research teams and other clinicians and whoever is interested will also use that data, because that data is available at the Data Trust, not only for my team, but any research team that is interested in using it. They just need to put in the request for the data, and we're writing an article to explain how that request will be. But really, the heart of this project, I would say, at least my main intention is that not only us, but other research teams and clinicians use that data too. So if you're interested in that, we can definitely talk more about that as well. And moving to Laura, and she's apologizing, she can't unmute. Um, she's saying, this is such an important topic. None of you will be surprised to hear me say I'm very interested in understanding how we can map health history data and link it to NANDA-I. And she also worries a little about the number of times nurse interventions are repetitive with data reflecting doctors' orders have been followed. Yes, that's true, Laura. And she's asking if I have any recommendations about what we can teach nurses about how to document. Wow, that's a great question, Laura, and how to document and how to improve the ability to code specifically. So I would say that the ability to code would rely more on the health system and not the nurses themselves, because the coding should come as part of the back end. So it needs to be an infrastructure already, and nurses should definitely be a part of making that code, but that can be done at the hospital level. But I think it makes a lot of sense, your question about how do we teach nurses how to document. What I've been doing with my own nursing students, so as part of my role, I do teach nursing students here at UF, is that I try to show them the importance of everything they document and why they're documenting it. Because sometimes they think it's just a busy task that they need to do because the hospital requires for quality improvement measures or performance indicators. But there is a gap with them understanding how we can use all of that information to make improvement. And I think if they understand how that data can be used to answer different questions and make changes to practice, I think that will reflect a little bit how they perform their documentation. So I think my recommendation would be almost like you do the opposite. You teach them first what the data is telling you in a sense of what are the findings you can get from the data, and then show that you can only get that if you document this way. So if you show the connection of the words being entered in the computer and all the knowledge being generated by that, maybe that would be more efficient. But I'm still trying that as well. So I think we still have a lot to uncover in this area. But at least that's what I try to do with my students. And this is something that the nurses tell me as well that work with me. One of the nurses that works with me, he's a clinical nurse specialist in his unit, and he's becoming one of the biggest advocates for our project. And he tells me that every time he talks to nurses, he tells them how many findings we can get from nursing data, and we can only find the things that are working for our patients because of the way we're documenting and how we're documenting. So he has been doing that work, which is great. And Cheryl is saying here, we're currently numbering the activities so that we can track the activities back to the intervention. Yeah, that is great, Cheryl. I think it would be great if we could also kind of streamline the activities, because some of them we might have many activities that mean the same thing and we just need one of them. But kind of want to talk to you, Cheryl, at some other opportunity, how you're numbering activities that when the same activity belongs to two different interventions, how you're doing that numbering. I'll be very interested in learning that. So we can definitely catch up, Cheryl, more on that as well. And Christine, I think I've answered all of the questions that are here on the chat. I don't know if anybody else has any other questions.
Yes, I'll open up the Q&A for any last questions for you. We'll give it a few seconds, but thank you so much for this informative question. I want to remind the audience that future NANDA webinars will be available on the NANDA website. And check back periodically to see that when new webinars are added. Our education staff is very active in helping people understand and use NANDA terminology in their documentation as well. So did we get another one? No, we didn't. I think that is it. Yeah, I think that is it on the questions. But thank you so very much on behalf of the NANDA International Organization. Thank you for this presentation, and you provided the link for your LinkedIn if there's any further questions down the road for you. So with that,
Absolutely.
we'll end today's webinar, and thank you so very much. And I wish everyone a good rest of your day.
Thank you so much, everyone. Thank you, Christina.
Thank you.
Thank you, Friso. It's been a pleasure. Bye. Thank you.
Thank
Okay,
you.
bye-bye. Thank you.